Hey, everybody. If you're listening to this, you are listening to the first free hour of this episode of The Shift with Doug McKenty. If you like what you're hearing, please consider subscribing to the show in order to access the full feature-length versions of the podcast, as well as have access to the members forum, where we discuss potential topics and interviews and dive deep into the overall concept of the shift. For only $6 a month, not only do you get the full-length episodes, but also an opportunity to co-create with me, your host, Doug McKenty, the future of the show. Go to www.theshiftnow.com or patreon.com/theshift and sign up today in order to help make the shift possible. Thanks for listening and enjoy the show. Good morning, noon, or night, wherever and whenever you are listening to The Shift. I am your host. My name is Doug McKenty. This episode was recorded on July 10th, 2020. Find out more about the podcast at The Shift with Doug McKenty on Facebook and YouTube, at DMcKenty on Twitter, or check out the website at www.theshiftnow.com. My guest on the program today is Dr. Richard Fleming, author of the book Stop Inflammation Now and inventor of the patented inflammation testing protocol known as FMTV-DM, short for the Fleming method for tissue and vascular differentiation and metabolism using same-state single or sequential quantification comparisons. After working as a nuclear cardiologist for decades, developing techniques using radioactive isotopes to measure the extent of heart disease, Dr. Fleming discovered that the root cause of arterial degeneration was inflammation caused by immune system response to a variety of stimuli. This discovery led to an ability to diagnose many patients who had previously slipped under the pharmaceutical radar by an overfocus on cholesterol. He set out to help patients by promoting a regimen of diet and exercise designed to reduce inflammation in the body, accompanied with a precise testing routine that charted a patient's progress towards health. Undaunted by a series of legal challenges brought about after his treatment protocols threatened to dismantle the foundation of the current and very profitable corporate medical paradigm, Dr. Fleming went on to invent FMTV-DM, which he discovered measures the inflammation that is the underlying cause for not only heart patients, but cancer patients, as well as any disease that results in the typical immune response triggered by the body anytime it feels under attack. The test can measure inflammation caused by bacterial and viral infections, including the infection caused by COVID-19. Stay tuned as Dr. Fleming describes how his testing system can measure the effects in real time of potential treatments for COVID-19 in order to more quickly and accurately determine a treatment protocol that works against the potentially deadly disease. Rather than testing for the presence of the novel coronavirus and waiting for a vaccine, perhaps it is time to focus on treatment protocols that can save lives in the here and now. Dr. Fleming's testing methodology can be used to determine if controversial treatments using inexpensive medicines such as hydroxychloroquine, zinc, steroids, antibiotics, or IV vitamin C work within days of treatment, without having to wait months for the completion of clinical trials. Find out more about Dr. Fleming's work at www.fmtvdm.wixsite.com. I would like to welcome Dr. Richard Fleming to the program, and thanks for helping to make the shift. Hello, Dr. Richard Fleming. Thanks for coming on the show. How you doing today?
I'm doing well. How are you today?
I'm doing good. It's great to have you on the show. I always enjoy talking to medical professionals, and obviously with COVID going around, maybe you can help enlighten some of us as to what's going on. It's been absolutely amazing, the amount of information that everyone's getting flooded with, and conflicting information too. I don't think anybody really knows what's going on here. So
there's an absolute overabundance of probably more misinformation than information, and more fear than actual knowledge, and approaching it like it's a medical topic that we should be approaching. I mean, even today, as people talk about the novel coronavirus, it was novel when we first started it. It's not novel anymore. We've had
right,
8-9 months of this now. There's nothing novel about it, and we should be much further along than we are.
Yeah, that's been my impression. Before we get too deep into it, though, do you want to just take a few minutes and kind of describe for my audience your history and your past and what you've got going on now?
Sure. I'm a physicist, nuclear cardiologist, also have a law degree.
Nice. Yeah,
Um,
comes in handy.
yeah, sometimes. Uh,
Right.
I got originally brought into the science field back in seventh grade when I was in elementary school. The JFK administration had been testing during the early 60s. A lot of kids. I have no idea how many places. I know where we were at. We were being tested. I know out in here in Southern California, they were also doing some testing because I've met some of the people since being out here the last few years that were actually in a very similar program.
Hmm.
But we were tested every year through elementary school based upon our aptitude and what we would do under certain circumstances. And when seventh grade rolled around, you have to remember this is during the Vietnam War and during the attempts to launch Apollo and during riots, civil rights, and everything else going on in the 60s. Kind of reminds me of the day.
Right.
They were selecting us out. So in my school where I was at, they selected 30 of us out and placed us in advanced programs. My area of aptitude, it turned out, was physics and mathematics. Um, I went through that process. I began some of the initial research way back then. I'm not even sure what year that is, but I do know that I have 52 years worth of research time that I've done different things in the areas of physics, in the areas of psychology, in the areas of medicine, in diagnostic imaging. I joined the American Heart Association in the mid 1970s. I want to say 76. I have to go look at it. Became the youngest member on the faculty, was on several committees helping to work on cholesterol and heart disease, helping to work on the ACLS, Advanced Cardiac Life Support Protocols. Um, by the time I got into medical school, the second thing the dean of the medical school told us was that 90% of what we would be taught was wrong. They just
Hmm.
didn't know what that 90% was. So they encouraged those of us with research aptitude to try to investigate those fields. 90% might have been generous, that we got 10% right. When I was in medical school, I was one of the 17 honors students. I got to do research on sodium, salt, and high blood pressure. I was the only one who got to do it on people. Um, when I was a grad student, I was also in charge of a rat lab for 1 year, one of the top rat labs in the country. My mentor has since passed away. One of the ways you know you're getting older is when you start looking at the number of people that trained you who have since passed away, and you start to realize not only the gift that they provided you by training you, that they won't be there to train somebody else, but just simply the passage of time and the loss that you feel as these great minds pass.
Yeah.
Um, when I was after medical school, I did my standard internship, residency, all internal medicine. I went in my cardiology fellowship, which was an interesting time. I got really brought into nuclear cardiology. It was not where I thought I was going originally. I was going to be one of the top cardiac catheterization doctors in the country. In fact, at Iowa, where I was a medical student at, that is where the intravascular ultrasound was developed by Wilson and White.
Hmm.
And I was there in the lab when it was being developed. It was also where Cine CT was first developed by Mel Marcus. And I was there in that lab when it was being developed, and we watched it. But by the time I got into my fellowship in Houston for cardiology, the brand new technetium compounds, which are radioactive tracers you can use to look for disease, they were experimental. And that's a very critical thing in my story of my life, because we went from using just thallium, which was a drug that we injected once, and we would then wait for the drug to get settled in the body, and we would take pictures of the heart, and then it would move around, it would redistribute, and we would take pictures several hours later, and we would compare those results. It was all visual.
Hmm.
um, when I came into the system, we had the brand new technetium compounds, and I worked on one of those, and then later got also trained in the other one. um, those compounds were interesting because they didn't last as long, so we could give higher doses of that and we get prettier pictures. But it turns out that is key to my story in life is that they misrepresented how many doses of these compounds you needed to do. They said you needed 2 because this stuff did not redistribute or move around. And my response to that is anybody who tells you that something goes into your body, doesn't move around, but just sticks in one place is either selling something or on something. Because nothing just goes in and sticks around. And it's the fact that they sold that bill of goods is almost impossible to believe, but they did.
Right.
They've interestingly done a little backtracking of that with the FDA, where they've said, well, look, it does redistribute, but we just don't tell doctors how to use it. So their stories have changed over the years. It did allow them to make tens of billions of dollars in extra sales. It allowed them to expose people to more than 3 million curies of extra radiation. And I know that that's not something that means a lot, but if you remember back a couple years ago, they shut down a Japanese reactor because it went Chernobyl almost, and leaked radiation into the ocean and shut down the cities. 3 million curies is 1/3 of what shut that reactor down. And
Right.
they also missed the most critically ill people. Now that's been discovered by a lot of people since, but nobody's fessing up to it as far as changing the way in which they're doing that.
And let me break in for just a second because I want to clarify. There's this very expensive compound that was being put into people so that you could take pictures, and it was radioactive, and you could take
Right?
pictures of their heart, find out how how far their heart disease had progressed. And the company, this is very expensive, and the company was recommending 2 doses. And then you developed the technique that only required 1. Was there like a time differential there too? They were saying 2 doses over time. You said no, 1 dose right
Yeah.
away.
What happened was there were 2 different drugs that came out. The one that I started working with, called tebaroxime, was very rapidly acting, and so you had to be right on the ball and you had to image right away.
Mm-hmm.
The advantage was is that you got information immediately. And the other company said, well, wait a minute, you don't. Look, that's inconvenient. We realize that you're all busy. So, look, our drug doesn't move around. You give it to the person, you wait an hour, you wait 30 minutes, you wait 3 hours. It's going to be the same picture. You just take your time. And that, of course, was embraced because, all the departments are fairly busy. And if you tell somebody, look, you've got a window of 3.5 hours to image versus you've got to start imaging within 5 to 10 minutes,
Mm-hmm.
they're going to take that first choice of, that big window. And so they said, but you have to give that second dose. And they've never explained how you can separate what shows up from the first injection and the second injection if it's still there. And
Right.
they really kind of sold the point of view that you have to have 2 doses. And I bought that. I mean, I believe that. Look, I came through the system. I did the research on it. They said it takes 2 doses. We use 2 doses. The first paper I published on one of them, which is the first nuclear paper published for SPECT cameras, a certain type of nuclear camera, was the first paper on it. And I said, this is the party line. This is how you do it, because that's what they said.
Mm-hmm.
It wasn't until I'd finished my fellowship and I was having a private practice, and the company came up to me and they said, we'd like you to do breast cancer imaging for us. And I said, well, look, I'm a heart doctor. They said, yeah, but your nuclear license allows you to image anything you want to image, including breast tissue. And they weren't getting a lot of people really doing the nuclear imaging of the breast. And I went, okay, well, let me think about it. If I can figure out a way that I think is right, that I can ethically live with, that seems appropriate, to look for breast cancer and or heart disease, let me think about it. I'll let you know. So what happened was I figured out a way to put both tests together with a single dose.
Mm-hmm.
What I discovered was that when you did the breast cancer imaging, to image the breast, you had to image right away at 5 minutes. But we were supposed to wait for an hour for the heart. But here's what I saw. At 5 minutes, not only did I get the breast image for breast cancer, but I got a heart image. And the heart image at 5 minutes
Right.
did not match the heart image at 60 minutes.
Mm-hmm.
They changed. In other words, the isotope moved around. In other words, the company lied through its teeth. And they did that. I mean, I'm willing to give people the benefit of the doubt. I'm willing to say, they didn't know, right? Because they didn't look. Well, you know what? That works the first time you tell that to somebody, but when you let them know and they don't change it, and then they say, no, you're wrong, and then you watch and see Sinai, Johns Hopkins, Emory University, and a bunch of other universities start showing pictures of the heart at 5 minutes and 60 minutes, and they're different, and they're going, well, we don't know what to make out of this because these images are different, but they're not supposed to be different because it doesn't move around.
Right.
And then what happens is that when I first presented this at national and international conferences, people went, Fleming, you're nuts. Sestamibi does not redistribute. Now what happens is you go to those conferences, and the only people who, and you say that to people, and they go, well, of course it redistributes. We all know that. But you go to the company, and the company still goes, no, no, no. But then to the FDA, they say, but remember, it's up to the doctor how they want to do it. We're not telling them how to do it.
Right.
So, they're saying one thing, and, just depends upon which side of their mouth they're talking at.
And this, are you giving a second dose? Like if you're doing the imaging after 5 minutes, you use less of the substance. Is that?
Well, it's never the same amount. They usually use, but here's the thing: it doesn't matter how much you give; it's the same cost.
Oh.
So if you give, say, 30 millicuries for the first dose and 10, it's a third. The second dose, it's the same cost. The benefit is that 10 millicurie dose came out of another 30 millicurie dose. So they took a 30 millicurie dose and they got 3 10 millicurie doses that they now got to bill from one dose, plus they're billing for the other one. And you can see how they made tens of billions, literally.
Right.
I think I
Exactly. Yeah.
calculated $20 billion in extra billing. And by the way, that's to the insurance company, that's to CMS, the federal government, all paying for these doses because everybody has bought hook, line, and sinker that the dose that you have to give 2 of them. And as I said earlier, if you give an initial dose and it's 30 millicuries and it sticks like they say it does, part of that's still going to be in the heart. Now you give a second dose and you look at the heart. Well, that 10 millicurie dose and the 30 millicurie dose, it's the same radioactive isotope. It doesn't look any different. So which one are you looking at when you take that second image? Is it what's left over from the first one, or is it what came from the second one? And the answer is it's a combination of the two. So it completely invalidates that approach for even pretending that you can look at the difference in disease.
Right. And so you're going up against a company that's making literally billions of dollars and saying we don't need to be, we don't need to be spending this much money on this substance and doing the test this way. And so, I guess the response from the company probably wasn't super positive.
Well, it wasn't super positive, and amazingly enough, I presented this at the Society of Nuclear Medicine and Molecular Imaging conferences, and there's an equation that you need to really tweak out the full details, but I gave it as lectures, speaking with the expert lecturer or something like that in Toronto originally, and the University of I think it's Kim Young out of South Korea came and listened to the lecture, and the next year they came back, and I was telling people that about 30% of the people had critical heart disease that was being missed because you only see it if you image initially at 5 minutes. By the time you wait for an hour like they want you to, or even 30 minutes, everything is filled in, so you miss the critical heart disease. The South Koreans came back and they said, no, it's 40% of the people that have critical disease being missed. These people get told they don't have heart disease, go home and die.
Right. Can you describe exactly what you're looking for when you are injecting the radiation? What is it that you're trying to see with that test?
Right. Well, there's actually two things to address there. To begin with, most of the tests are qualitative or visual. So you're looking for where the isotope shows up one time and doesn't show up another time.
Mm-hmm.
Okay. So if it shows up at both times, then that's considered, quote, normal. If it doesn't show up when you're, quote, stressing the heart, but it shows up at rest, that means you have coronary artery disease. If it doesn't show up on both times, then you have damage to the heart. The truth of the matter is, however, when I did all of this, I discovered and then eventually patented a method
Mm-hmm.
that's useful not only for heart disease, but cancer and COVID-19. I showed that the way that we use our nuclear cameras, the cameras are calibrated qualitatively. In other words, the nuclear techs spend a lot of time making sure that when they put something radioactive in front of the camera, that it appears uniform, that it's consistent, that it's linear, that it matches. But there is no nuclear camera used outside of the use of this patent that quantitatively calibrates the camera. In other words, all of these imagers are based upon the information it's counting coming from the patient. But nobody asked the question, are the cameras counting correctly? And
Mm-hmm.
it turns out that as they have tweaked the cameras over the years to make the pictures finer and finer with more and more resolution, the cameras lose information, which means that the picture that's made is made as a result of losing a third of the information.
Mm-hmm.
So the patent that I have allows you to look at the image, because I realize we're visual images, we're visual creatures, we want to see it. But more importantly, once the camera is calibrated to know that it's counting correctly, we then take the counts and we look at the counts and we compare the counts to see what's really happening to the heart. And we take that same information and then we get very sophisticated information. But again, you only need one injection with most isotopes.
Mm-hmm.
There's a couple isotopes that only last for a minute or minute and a half that you do have to use two isotopes, but because they're so short-lived, if you wait an hour between them, that problem of overlap that I talked about before doesn't exist because it's gone. It's gone in every 72 seconds.
And so are you looking for cholesterol levels here or blockages to the arteries or
Okay.
what is what
Okay, good,
determines,
good,
the
good
heart
question.
disease?
So coronary artery disease is not what people think it is.
Mm-hmm.
It is not a narrowed artery, although a narrowed artery is coronary artery disease. So explanation. Turns out that this Russian physician by the name of Glagov published in a little-known journal called the New England Journal of Medicine in 1989 a series of patients that were found to have heart disease. How did they know? Because they dropped dead from heart disease. And the lumen, the area where the blood flows, the part that you see when you see an angiogram, were completely normal in all of these people. Well, if it's a narrowed artery that's heart disease, how can you drop dead from a heart attack and have heart disease if the lumen isn't narrowed? The answer is simple. The inside of the blood vessel has blood pulsing through it. There's resistance there. The outside, which is formed of many layers, has a buildup of cholesterol or triglycerides or homocysteine or oxidative damaging materials or bacteria or viruses or the
Mm-hmm.
things that I talked about in the inflammation and vascular disease theory back in 1994. All of those things build up and the body goes in with its immune system, just like with COVID-19, and tries to deal with it. And they get inside the arteries. And what happens is that instead of the artery, if you can see my hand like that, what happens is that the disease pushes the arteries out. That's coronary artery disease. And only when it can't go out any further does it then finally erode into the center part. 85% of all heart attacks occur in people that have less than 30% narrowing. And half of the people find out they have heart disease by dropping dead from it.
Mm-hmm. Mm-hmm.
So, inflammation, so a little bit more. So, your artery is this. Your arteries of your heart are unique. They have the ability to relax and increase blood flow, and that is called flow reserve.
Hmm.
And the guy who wrote the equation for dogs is the guy who trained me. The guy who wrote the equation in people, that's me. I wrote that equation back when I was a cardiology fellow. The ability of an artery of the heart to relax, flow reserve, it can increase and carry 5 times as much blood at peak demand as it can at rest. Now, how did I prove that? And I presented this at the American College of Cardiology conferences in Anaheim back in the early 2000s. I took a bunch of people that we were worried who had angina, chest pain from their heart. I laid them on a table, an imaging table, where we were going to do images of their heart with these nuclear isotopes. They had no chest pain. They weren't exerting themselves. I gave them a medicine to relax their blood vessels. They developed chest pain. Now, the blood vessels that were good did this and carried more blood. The blood vessels that had disease did this.
Mm-hmm.
They both had more blood. The heart wasn't working any harder. So they shouldn't have had any problems with chest pain because they weren't working any harder when they were at rest and they didn't have pain. And now they all have more blood flow. So why did they have chest pain? And then I gave them a medicine to reverse the effect of the drugs, and their arteries did this, and the chest pain went away, less blood flow. What causes angina? Regional blood flow differences.
Uh-huh.
One area gets substantially more blood flow because its artery isn't diseased. Another one gets more blood flow, but not as much, which raises really interesting questions from my point of view as a researcher, which is it oxidative stress? Are these free radicals being released? Is there a chemical mediator that's going on? It's not magic. Something is giving signals neurologically that says the blood flow is different. How do we treat angina? Well, we don't reverse the effects of the disease. We bypass it to improve the blood flow, so they're both the same. Or we do laser therapy, or we give medicines to try to allow this to relax. We are manipulating the regional blood flow differences so that they are equal. You have angina long enough and you're at less risk of having a heart attack. Why is that? Because the bad blood vessel gets new blood vessels grown to it from the good ones. It's called collateralization or
Right.
neovascularization, different terms depending upon when you were trained. They share the blood flow, so there's no longer regional blood flow. I gave that in an hour-long conference at the American College of Cardiology. There were only 8 of us invited to do this. I was one of the 8, and you got to answer in response to that afterwards for a year and get physician credits. Jeff Eisner, who's the doctor who did laser therapy, who was on the cover of Time magazine for introducing a laser therapy, transmyocardial revascularization, TMR, or laser, got up right after me and he gave me the best compliment I've ever had in my life. He said, we're going to show you how TMR works. We're going to show you some nuclear images, but I can never tell you this as well as Dr. Fleming just told you. And I went, if I die right now, I'm good. Jeff Eisner just gave me a compliment that I don't know as I deserve. I was honored, but it's like, if I die now, I'm good.
Right.
Jeff unfortunately has passed away from cancer himself, but another one of those stellar minds that we owe so much to.
So this was back, and again, you're trying to figure out then what's causing the elasticity difference between blood vessels. Some remain elastic, others are not expanding and contracting the way that they used to.
Right.
And I guess, I mean, my complete layman's brain is going to cholesterol. Like there are all these other explanations that doctors have given, and over the past decades.
Right. And so to be fair, I was on those cholesterol education panels that first talked about that. I mean, I was on those panels. I was on the panels that helped develop the Nuclear Cardiology Board test the first year it was given, first couple of years it was given. I've talked the talk. The only difference is that when I realize that there's something that's wrong, I will change that over time. And so for many years, and I was on the panel that helped change the cholesterol guidelines and bring those down. But I literally back in about 1999 said, look, and I was the cardiology fellow who did the Dean Ornish patients. Okay, I mean, I was the guy so I'm trained in nuclear, both planar cameras, SPECT cameras, and PET cameras, all 3 devices. and we did mostly PET with those patients to evaluate them. And I looked at that, and in 1999, I just stepped back and I said, look, Fleming, if it's just cholesterol and just triglycerides, like we've been talking about, shouldn't this be cured by now?
Right.
Right? I mean, we're hitting it with drugs. We know about it. Is that the thing? So I sat down and I said, okay, let's pretend that maybe we don't know everything that's going on, and maybe some of these other people that are talking about different ideas, maybe they're right. So let's figure out what people are talking about. So I started by looking at just the cardiology literature, my bias, right? Because we should know it, right?
Right.
Heart disease. Um, um, okay, that didn't really help. And so I said, well, okay, maybe these internal medicine doctors, they're you have to do internal medicine before you can go into fellowship in cardiology. Maybe they know. I mean, they're seeing these patients. First doctor who ever said that having a high cholesterol level was an OB-GYN in the 1920s, 1930s. I don't remember his name, but
Uh-huh.
he got reprimanded, and lost his college, kicked him out. They said he wasn't a serious OB-GYN doctor because all serious OB-GYN doctors only take care of pregnant women, and they don't worry about this cholesterol nonsense that he was talking about. But what he noticed is that the women who were having chest pain with their pregnancy all had high cholesterol levels.
Hmm.
Depending upon who you believe, whether you believe Ansel Keys or whoever, doesn't matter. The reality is if something is not completely answered with what you keep digging into it. And so I did internal medicine. Then I said, well, you know what, maybe the nutritionists, dietitians know something we don't know. Read their
Right.
stuff. And then finally I said, wait a minute, maybe the United States doesn't know everything. Maybe I should look at what the other countries are doing. So I spent about 6 months doing that. And as I'm reading, I'm making a new diagram. I don't know if that's one of the ones I've given you. But I developed so in 1994, 1995, I started presenting this at American Heart meetings, and I got told, no, you can't be right. It can't be inflammation. It's cholesterol. Women do better if they're given hormone pills. And that was the year that they actually showed that the women who got the hormone therapy ended up with more heart disease.
Mm-hmm.
So it's like, yeah, okay, tell me that one again.
And
Um,
just to clarify, when did you change your mind? When did you discover that it might be inflammation and not cholesterol?
well, so cholesterol plays a role in the inflammation.
Yeah.
Okay.
Okay.
But the theory when I first came out with the theory was in 1994. I kept digging into it, presented again in 1995. By 1999, I had everything put together, including the figure that went into a textbook. And then we talked about it briefly on 2020 in 2004. And for the life of me, I hear all these people who go, yeah, we've heard about inflammation and heart disease. And then when COVID-19 hits, and I'm saying the reason why people are dying with COVID-19 is because they're dying because of the immune response to the virus, the inflammation and the blood clotting. You people are not familiar with my theory, because had you been familiar with my theory, or if you'd have read the papers that I published where we took bacterial infections that made heart disease worse, and we discovered when the thymus gland got activated and how the blood tests changed and the heart disease got worse, and then we treated the bacterial infection and they developed antibodies, the inflammation went down, the heart disease improved. It didn't go normal,
Mm-hmm.
because it wasn't just due to the bacteria. Now, if you'd have read that stuff, you'd have been prepped for COVID-19. But the treatment for COVID-19 so far, with the hundreds of thousands of deaths as people are finally getting tuned into, is because of all the inflammation and the blood clotting happening. And it's happening because of two groups of people. It's happening because of the immune naive people, the very, very young, and you're seeing this now called multi-system inflammatory disease. Great cute term to say, oh, we've discovered something new. No, you haven't. They're immune naive. So their immune system, think of it like a teeter-totter, doesn't know when to rein back when it's been activated, because it has no experience. It hasn't learned.
Can I,
And
Dr. Fleming, just really quickly before we get into this, because I want to just make sure that my audience can understand this connection with the inflammation that where you discovered that inflammation was the root cause, that, and the other things that everybody thinks is the cause, the cholesterol, the triglycerides, everything that I think a lot of lay people maybe have heard of in association with heart disease,
right,
that you were able to actually narrow it down and go, wait a minute, this is just inflammation. And not only that, but then you saw it in other things like cancer
right,
and, that, because I've actually heard this, I think, from more from the nutritionist angle, which is that inflammation is the root cause of all disease. And if people could start to figure that out, then we could really get to the cause instead. And that's, one of the reasons why
right,
I think you're really onto something here. Almost one of the fascinating things about your story is how challenging it is to go up against the pharmaceutical and the medical establishment to
yeah,
go, hey guys, this is what's really going on. And then we can, if you can kind of clarify how you discovered this, that inflammation is the root cause, and then we can go on and connect with heart disease and COVID a bit later.
right, right. Well, the way that I discovered it was to take the bits and pieces of work that everybody was doing and put this together in a theory to make it fit. And what I came up with was essentially 12 different factors. And once I had that put together so that it made sense, then I began testing it. Then I began imaging people, doing nuclear imaging,
Mm-hmm.
and measuring all these blood tests and seeing what happened to them over time. And what we saw then were the changes in these blood tests. And cholesterol may be what causes it in one person, and it may be homocysteine that causes it in another person. And one of the early ways that I said that this should be thought of is think about it like a spider's web with 12 different spokes coming out, all 12 of these factors. The spider knows where you're at if you touch the web, no matter where it's at, because
Right.
touching it in one part has an impact on everything else. So what might be the primary motivating cause of heart disease for you might be different for me, because I'm sure you've heard of this. We are all genetically somewhat different.
Yeah.
And the reality is that it's not one thing or the other. What you introduce into your body, the air you breathe, the including cigarettes or cigars,
Sure.
the alcohol you drink, the food you eat with the high fat, high cholesterol, extra calories, processed foods, garbage, the lack of exercise for taking care of your body, which is associated with increases in the blood clotting factors like fibrinogen and homocysteine, the failure to do the things to take care of and nourish your body, and the ingestion either through the air you breathe or the what you drink or what you eat all plays a role in how your body is affected. And then your body, based upon your specific genetics or genome, will respond to that
Mm-hmm.
differently than my body would. Well, so telling anybody that you can just take a cookie cutter and go, this is going to equal heart disease in everybody doesn't make sense. And when you measure it, you'll see, well, I saw that, for one person, it might be cholesterol. Bad cholesterol. For another person, it might be triglycerides or saturated fat. For another
Mm-hmm.
person, it might be homocysteine. It might be lipoprotein little a. It might be the onset of an infection that has just simply finally tipped off the
Right.
final common denominator. But in
Because
every one of those instances, your immune system is coming in trying to clean it up.
exactly, yeah.
And
It's the immune system that causes inflammation because
right,
it's cleaning up whatever toxin you got exposed to
right,
for whatever
right.
reason. Yeah.
So to do that,
Okay.
your immune system releases chemicals to tell the rest of your body that it needs more help. Well, those chemicals are designed to destroy the thing harming your body.
Mm-hmm.
Okay, that's great. Your immune system is doing a beautiful job. If it's because of what you're eating and taking into your body, your immune system is doing what it was designed to do, protect you, but the enemy is you. In the instance of the virus, the enemy is the virus or the bacteria. So your immune system is doing what it's designed to doing. It's going in, it's eating the garbage that shouldn't be there, it's releasing chemicals to try to kill that garbage. But unfortunately, those chemicals, any place else that there's inflammation, is going to kill and do damage.
Mm-hmm.
It's going to try to form a blood clot around that area to isolate the damage. So it's going to form a blood clot anywhere there's a blood clot. One of the things to be aware of, by the way, when we're talking about the transfusions for antibodies, that's plasma. And plasma has plasminogen in it and fibrinogen, which promote blood clotting. So when they're giving that, if they're not thinking, oh, wait a minute, we could be increasing the blood clotting, they're going to have problems because of the blood clotting. And they're
Right.
not thinking about that because I'm reading what they're thinking about and it hasn't come on their radar. They're not familiar with the inflammation theory. They're unfamiliar with this. So they're
Yeah.
and we're talking something that was presented 25 years ago and it was on 2020 and 2004. So you might not listen to me at American Heart. You might not even read the textbook chapter, but by God, you're listening to shows like 2020. The New England Journal of Medicine published several papers that said when you put a patient on a ventilator, if they've got this inflammation going on in their lungs, called acute respiratory distress syndrome, ARDS, you cannot give them the amount of ventilation or air with each breath
Right.
without stretching and causing more inflammation, or you will kill them.
Yeah.
So the
Yeah.
hundreds of thousands of deaths are due to the body doing what it's supposed to and people not paying attention or treating what they need to be treating and saying you're dying from COVID. No, they're dying with COVID and a failure to target treatment at the problem.
Yeah.
And I
Yeah.
get
I
it,
hear you.
you're overwhelmed.
I mean, what I'm starting to hear here is not only, are you discovering things that, hey, we're doing this test. I think we need to cut the dose, and the pharmaceutical company is going to make a lot less money. But then
Right.
also now you're saying, well, cholesterol isn't really always the cause of heart disease. We need to be looking at inflammation. This is also going up
Absolutely.
against big pharma, right? You're talking billions and billions of
Oh
dollars in
yeah, yeah.
cholesterol drugs.
There's nothing about me that's making friends on that. But but
Right.
but bear in mind, I'm doing it all from the perspective that I'm going. Look, I have this test that's patented
Yeah.
that I'm allowing to be used for free for COVID because, yeah, I could make money from it, but it's more important that the people get treated properly for COVID with this test. But this test will also look if your treatment works, this test will show it. If your treatment doesn't work, this test will also show it.
Right.
My stupid perspective as a physician is, don't you want to be using the best treatment for this patient? My idiot thought from Big Pharma's perspective is, we'd like you to use our drug, but only if it's helping you. And if it's helping you, we want to be able to prove that it's helping you because then we feel good about selling you our drug. Are
Yeah.
there not enough sick people on planet Earth to pay for Big Pharma and those that are protecting Big Pharma in the system?
Well, this is just the same old story. I've heard it so many times, and I've had the same experience with COVID. I mean, people started talking about hydroxychloroquine right away. I
Yeah,
thought, well, this is interesting. I read an article on Medium, somebody really explaining, well, there's this, and this was in early April, I think. It might have been back in March. I mean,
right.
just, the guy was a PhD. I think he was an MD, but, he just wrote an article explaining, like, there's this blood clotting going on. And I'm
Yeah,
thinking, well, that's kind of interesting. It's different than the
right.
flu, and they're putting the people on respirators. Even back then, I'm thinking, and again, I'm not an expert. This is why I'm enjoying this conversation to learn about this. But, I'm thinking they're putting these people on the respirators and it's not working. We started hearing 88% of people in New York City are dying once they go on the respirator. We're seeing eyewitness doctors coming out saying these people are dying. We're putting them on the respirator. It's not working. And yet the system couldn't change. Then I saw peer-reviewed studies coming out of Italy, and this was probably in late May, where they had done autopsies and then clearly, I mean, this information was peer-reviewed. It's not even like you're talking about. Why can't doctors read these if I can read the peer-reviewed studies, why aren't they figuring out that this is a blood clotting thing? This is not, you're not treating it right. It took them
Yeah.
until a few weeks ago just to finally go, well, maybe this steroid will work.
Yeah,
Well,
and that steroid, just to be clear, that steroid is not going to work all the time.
yeah.
That's dexamethasone, and there's two inflammatory components. There's the initial cytotoxic, which means your immune system comes in and tries to kill the cells that are infected.
Mm-hmm.
And there is the delayed, which is not that delayed when you get around to it, it's somewhere around a week, humoral antibody response, where you're trying to make antibodies. All right. In both instances for this communication, they have got to release these chemicals, interleukin 6, tissue necrosis factor, and a variety of other chemical messengers that say to the rest of the body what's going on, and they activate this entire process around the body. If you use dexamethasone, you will shift the emphasis from the first to emphasize the antibody response. It shifts the cells. That can be a good thing, and you're seeing that it's beneficial in some. However, if you give too much, it shuts down your immune response. There's nothing controlling the virus. The virus runs amok, and it promotes more inflammation, which only makes it worse.
Right.
Yeah.
Yeah.
And every time somebody says somebody has a bunch of infections going on with COVID-19 that caused their death, I'm very leery about that, because the data shows me that's probably not what's going on. So let's talk about a couple. Are you ready to talk about some of the COVID-19, or you
Well,
want to talk about
actually,
something
yeah,
else?
I think we should save that for the second hour, just
Okay.
because we can put some of this behind a paywall. Whereas I want to make sure that we cover. I want you to be able to talk about the lawsuit a little bit,
Yeah.
and also a little bit more about the your methodology, the FMTVDM,
Right. Okay.
here in the first part. So, um,
So yeah, let's
yeah,
let's talk about the uncomfortable lawsuit.
okay,
Okay,
yeah,
let's
yeah,
talk about the elephant in the room
right.
that has been sitting on my chest for a long time.
Because of course people are using this to say, oh, that Fleming guy, he was a part of this
Yeah.
lawsuit. No need to listen to him.
Yeah,
Right.
and that's one of the reasons for doing this, and for having that segment that explains it. So
Yeah.
you remember, I told you the amount of time I've been doing research, and the dean of our medical school saying 90% of what we teach you is wrong, and
Mhm.
I'm already seeing that things are wrong. And the very pharmaceutical company that caused the issue was the one that said, "In Dr. Fleming, would you do breast cancer imaging for us?" And I remember the first time I did that, I said, "Well, wait a minute, why don't you have the other doctors do this in their area?" And they go, "Nobody here will do it." I said, "Well, why not?" And they said, "Well, because they're getting test results that say there's breast cancer, and then they go in and they take the tissue out and there's no breast cancer." And I said, "Well, they're saying it's abnormal. Is the tissue abnormal?" Oh, they didn't know.
Hmm.
So wait a minute. So the basic question you should have asked was, is it abnormal? If they say that the image is abnormal, there's something wrong, and the tissue isn't normal, then the test isn't wrong, right? So we did the first test, and because of the way I did it, it ended up leading to this patent. We were enhancing the blood flow because I was combining the breast cancer test with the heart test, and I needed to use those chemicals to relax the blood vessels. Well,
Right.
guess what? Cancers are blood rich. Okay, so when they are there, or there's inflammation, when you use those chemicals, you shift the radioactive isotope for the imaging to those blood rich areas.
Oh,
And
wow.
because they're more metabolically active, cancer and infections, those cells take up more of this isotope. So you shift the blood flow, you give it to active cells, and it lights up. And then once you've calibrated the camera, you can actually measure what's going on. And that's what showed me that people were lying. So we did the
Hmm.
first test, and we had the image, and it was black and white. And I remember the drug pharmaceutical rep being there in the room, and she went, "Shoot, this looks abnormal, and it's probably not. Do you want us to talk to the people in New York, and you can talk to those doctors?" And I said, "Why do I need to talk to them? I mean, I'm a nuclear cardiologist. You came to my office to do this. I don't need to talk to somebody in New York. I can do this." And I said, "By the way, have you ever looked at this in a color format?" And they said, "No, it's always black and white." And I said, "Well, let's try something. Let's go to blue green." They said, "Why blue green?" I said, "Because the human eyes are most tuned to blue green." So we turned it to the blue green scale, and guess what happened to the areas that looked abnormal? They went away.
Huh.
They were gone. And she went, "Wow." I was like, "Oh God, I'm working with people who do not know what their drug does." And in fact, that same company has told me,
Right.
"We don't care about whether this is useful for breast cancer. because we don't have a marketing strategy for it. We just want you to push doing it and then promote it for heart disease because that's where we make our
Right.
money. It's like,
Well,
wow, okay. So,
what did
yeah,
I there was one phrase that you used in one of the videos that's coming to mind now, that why can't people they're instead of doing the job, they're keeping their job, instead of healing people and
yeah,
the job
yeah,
of being in medicine, they're just doing what they got to do to keep the job.
yeah. And it's, and look, I know that people get overwhelmed. And I know that they're not all researchers. I know that people like myself are the odd duck out. In fact, I've told you
Yeah.
that I've written a book on COVID that we've sent off to the publishers now for publishing. And there's twice in the book, I think, that I have a footnote that says, because it talks about something complicated. Now is the time for you to call that nerd from high school that you always picked on and say, thank you for doing this work.
Yeah.
Okay, because I didn't do it all. I mean, I'm not the guy who sorted out codons for what tRNA comes in to make the proteins that are being translationally made with ribosomes. So somebody else worked that out. And I don't reinvent the wheel. Call them up, say thank you for doing that.
Yeah.
By the same token, you might want to start calling up some other people and saying, I'm not sure what you're doing for us for COVID. There's a lot of fear and a lot of misinformation, but I haven't seen anything come out of your office yet that has given us any hope. And considering how many people have the virus, we really should have some treatment protocols laid out by now, because if 3 million people isn't enough to do it, I don't know what it's going to take. And if hundreds of thousands of deaths worldwide hasn't been enough for us to focus on the treatment, we don't have it yet. But let's go to the court case, because I want to wrap that up and get it
Yeah.
done so
Yeah.
we can move
Okay.
away from me to what's
Yeah.
important, taking care of the people. So I started doing this protocol, and I had a really good nuclear technologist who I lost because he liked to do parachute jumping, and he did 3 parachute jumps on one day and broke his ankles on the third jump. So I lost him, and we ended up with another girl, a younger woman, early 20s, who was trying to get back to the area, and she didn't like what I was doing. And my understanding is she went to the government and said, he's only using 1 dose. This isn't how it's done. And the government came in and got very, very upset, and eventually indicted me
Hmm.
for billing fraud, which means for billing for a test I didn't do, and then eventually for a soy chip study where, because of family members that were getting this soy product for health problems, I agreed to look at 60 people who would take this soy chip product and see if they lost weight, which didn't seem like a real challenging job. You give them the soy chip, they're either going to lose weight or they're not.
Right.
Um, and the government said, well, you made up some of the data. They didn't even say how much. They just said, you made up some of the data. You didn't do 60 people. And they did that based upon people that weren't even in the office. And so I went to court, and I couldn't afford an attorney, so the public defender presented my case.
Hmm.
And I remember talking to him. The government, by the way, waited to the last minute, within a month of the 5-year statute of limitation to file charges. And then they filed it. And, he said, I'm too busy. I'm overwhelmed. You're going to have to find your own evidence to protect yourself. So I did. Remember, I told you those 5-minute images and 60-minute images are different. I said, here, present these in court. If they're the same, everybody should be able to match them up. Huh? So if they're not the same, then they really are 2 different images. No, we
Right.
can't do that, because we can't do that. I got something from the American Medical Association that said, well, Fleming, not only did you not overbill, you underbilled. You could have also billed for this. Okay, so I underbilled. I had billing experts who said this is the way to do it. And I had the government's, it's called the R5 CMS coding book, that said, if you do the test this way and this way, the way I did it, and you have to bill this way, the way I billed it. Did that get presented in court? No, it did not. For the soy chip stuff, how do you present and prove that you saw 60 people?
Right.
Well, you get a statistician to prove that the data can't possibly be made up. So I did that. And boy, did that tick the public defender off.
Huh.
So he said, I'm going to show you that I can fool that statistician. This is the guy defending me, right? So it seems like the guy who's prosecuting me, this guy defending me, and he says, because I took mathematics in college and I'm very good in mathematics. And there was somebody in his family he talked about. So he was an expert in mathematics. So he took my data and he manipulated it. He plagiarized it and changed it. And he sent that to the statistician and said, that's fake data. And so what they did is I talked to them. They said, we started from the point of view that you lied and it really was made up. We presumed you were guilty. Oh, thanks. Okay. We
Right.
developed a test 5 years after the study was done. They developed a test from scratch to statistically look at the data, and they concluded my data was valid.
Sure.
And then they said, but this other data that's called faked data that the public defender made up doesn't quite look right, but we can't quite sort out what's wrong with it. So, absent knowing it's fake, we wouldn't know that. So, we get to trial. Okay, one more thing. So, the public defender says, oh God, I can't have that going to trial with my name on it. I will become a witness and I will be in trouble. So, he tells her, the statistician, make a new report, eliminate my name from it, any reference to me, so it doesn't show up. So we get to court and she's presenting this and she says the data shows the data that the Fleming data is innocent. The prosecutors get up there and they go, well, what about this first report? First report? You know, the one that has the public defender's name in it. Stop. Time out.
Yeah.
Sidebar. Sidebar. And I've given you a copy of this to listen to. The judge, the prosecutors, and the public defender are at the sidebar. And the judge decides that the jury does not need to know the whole truth and the wool can be pulled over the jury's eyes. He literally, honest to God, says that. They're not going to know it. Now, and the public defender doesn't defend the expert statistician. He throws her under the bus, but he does say, well, that's the thing, Your Honor. He says, I didn't fake the data. I used Dr. Fleming's data to make my data. And the judge says, well, that doesn't matter. That doesn't matter. She thought it was fake. Well,
Sure.
and the statistician that wanted to show up at trial that would have shown that the public defender plagiarized my data because he ran statistics on it and he gave that information to the public defender showing that he'd been caught lying and that the data was really plagiarized from mine. That person didn't show up. So what happened is that after 3.5 weeks and seeing this go down the tube, I was in the middle of a divorce from all of this. My youngest son had ended up in the emergency room once bleeding from his nose, and I said, I'm going to protect my son. My son wanted to be with me. So I finally said, okay, what type of plea deal can I do? Okay, I did the test this way, and I billed that way. The exact way the federal government says you must bill. And one of the packages that was sent did not have 60 patients in it. I didn't say how many patients are in it, and I didn't say anything was made up.
Mm.
That was good enough. Several months passed because of court things. The day before I go for sentencing, the family court gives me custody of my son. Now, I don't know if you've been to family court, but they don't really tend to give custody of a child to the father. Particularly, I think, when they know that he just went to federal court. And what happened? What happened? They gave me custody the next day we go for sentencing. The public defender said, Fleming, you either say yes to everything the judge says and you sign this document as it is, or he will throw you in jail and you will not be able to take care of your son.
Yeah.
Okay, I'm in.
Yeah. Cop the
So
plea. Yeah.
nothing I pled to was a crime. They felt ecstatic because it was a win for all of them, and I protected as best I could my son. I have two responses. You're either going to understand that and appreciate that and go, yeah, that sounds valid. And you've heard the tape and you have the other material if you want to splice it in here to use whatever for this when it goes out. And the other thing is that if you are the type of person who would put yourself before your children, I don't want to talk to you anyway, because you and
Yeah.
I have
Sure.
nothing in common.
Sure. Well, I mean, I'm just listening and I heard your story and it reminded me, I did a, I did an interview one time with Del Bigtree, who produced the movie Vaxxed, and then I actually ended up doing an interview with Andy Wakefield as well. But Del was telling me that he talks to doctors about the vaccine issue, and if they're going up against big pharma, people will literally say, well, I don't want to get Wakefielded, because Wakefield lost his license and ended up
Right,
having to leave England just for doubting. Really, and all he did was just questioned that maybe the MMR vaccine might have had something to do with autism, and he requested further study, and that
right.
that made them mad enough. And now there's this verb out there, getting Wakefielded, when
Yeah,
you're when you're going up. And I don't want to bring up the vaccine issue at all, really, but it just is, this has happened time and again. I've seen it
yeah.
over and over, where a physician will go up against the pharmaceutical companies, and the next thing you know, they find themselves in some kind of legal battle. I want for you to explain a little bit more about this inflammation thing, and then, because we have maybe 20 minutes left, if you want to talk a little while longer. It's been a bit, I know, but a couple more things I just wanted to cover. And one was this, because I think that one of the things I didn't understand was why so many people with comorbidities are dying with this thing.
Right,
And so one of the things, I think, if I understand you right, you're saying that COVID, because of the inflammatory response, COVID in particular, like if you get the flu and you have comorbidities, it also affects you. But it seems like COVID really creates this inflammatory response even more, so that if you already have an inflamed immune system, as you say, it's like throwing a match on a gas,
right.
and it causes an explosion.
Right. So the reality is that the more your immune system reacts, any other place in the body where there's an inflammatory process going on is already predisposed, it's already activated.
Mm-hmm.
So the damage that's occurring, I mean, remember, these chemicals are being released throughout the body. When the immune system comes to the lungs initially to address this, the chemicals that are released are going out in the bloodstream and lymphatic system, spreading it all over the body, calling for help from everywhere.
Right.
And so if you have immune cells where you already have heart disease or cancer or whatever, and they're responding, they will continue to respond and attack where that inflammation is going to.
Mm-hmm.
My speculation, and this is only speculation because this is the best that I can do, and any other expert out there who wants to chime in or give their 25 cents worth are welcome to, is that, this is a virus different than what we've seen before. We've seen coronavirus 1. This is different.
Mm-hmm.
And my speculation is that because it is so much sufficiently different than what we've seen before, our immune systems basically will go, wow, look up, guys. This is completely different than what we've seen before. Really an outside invader attack.
Mm-hmm.
And so I think that there probably is a little bit more priming of our immune response to this, which is what it's supposed to do. What you've never seen before, you will get a significant response to. Kind of like the first time you get chickenpox. The question is, it's different in chickenpox. Varicella virus is a good example. Some people get a fairly mild response. Other people really do get a reaction to it.
Yeah.
And if you get it near your eye, you can go blind. Do you know what happens to chickenpox virus after you get over it?
Hmm.
Does it go away?
It stays in your system, doesn't it?
Stays in your system. It goes back to what's called your dorsal root ganglia,
Mm-hmm.
which is the spinal part behind in your back. And later on, when you're weakened and immune suppressed, have diabetes or cancer or whatever, you get very, very old, very frail, can't keep things in balance anymore. This homeostasis we talk about. This virus comes back out along that nerve, and that shows up along your skin. So it's called dermatome patterns. And
Mm-hmm.
it comes up and it feels like somebody lights a match to your skin. That's the first thing that people feel, this burning sensation. Then they see the blisters. That is the varicella zoster re-exposing itself. Then you treat it and it goes away. But what happens to those people? They've gotten more and more weakened to it, and it tends to recur more and more frequently.
Mm-hmm.
So if you've never seen a virus before, your most dramatic response is probably going to be there, but it's going to be dependent upon your specific genetics, just like we talked about with the heart disease and the cancer. So some people are less inclined to have a more rapid response, other people more inclined to have more of an aggressive response. But no matter where they sit in that spectrum, if they have neither seen anything before they're immune naive, or they already have an inflammatory response going on, that little additional lighting of the match is all it takes for the rest of this to take off and
Right.
form blood clots and do more inflammation and cause heart attacks and strokes and loss of limbs and kidney shutdown and GI problems, everything that's actually killing the
Hmm.
people when they really do the autopsies.
And what causes the blood clotting then?
Okay, so part of the 12 factors is something called the complement cascade. And the complement cascade gets activated when there's damage to tissue and blood vessels.
Uh-huh.
And so anything that causes that damage, whether it's, we go in with a cardiac cath or you get your arm stuck for a blood draw, that causes damage. You have the virus go in and the immune system comes in and releases chemicals that tries to destroy tissue. So that destroys tissue. And what your body essentially does is it says, look, you could bleed to death. We don't want you losing blood. Now that's what happens with the final blood clot that causes a heart attack, is you form this blood clot. And the reason why is because this inflammatory plaque in the arteries inside your heart, feeding your heart, ruptures. And where does it rupture? It ruptures inside where the blood is flowing. That's where it ruptures. That's
Mm.
the final thing. And your body recognizes that tear as, wait a minute, the same thing as if somebody took a knife and sliced your arm. Wait
Right.
a minute, I could bleed to death, form a blood clot. It doesn't know that it's on the inside of the arteries. It doesn't know that it's on the inside of something else. It doesn't know that it's on your arm. It knows you're losing blood. There's been damage, form a blood clot so the person doesn't die.
Okay.
There's also the role of walling it off and clotting an area up to deprive it of blood flow so that nutrients to the infection or nutrients to the cancer can't get to it for the infection to thrive.
Hmm.
So for two different reasons, what's called the complement cascade gets activated for different reasons. Some that I won't bore you with, but it's in the original theory.
Yeah.
But it's your body stating, don't bleed to death, stop the bleeding. Or stop infecting the body, we're going to kill you by walling off your blood supply.
All right. And the key is you got to get to it before it stops,
Right,
prevents blood from getting to the good parts too.
exactly.
Yeah.
It's like when you go to fight a fire. You cannot fight a wood fire the same way you fight a grease fire, the same way you fight an electrical fire. That's why when
Hmm.
the fire department comes, they try to figure out what started the fire so they can put it out. Because if you're using the wrong treatment for the fire, you will not put out the fire. You will make it worse in some instances.
Hmm.
So when the problem is an inflammatory and thrombotic or inflammothrombotic response precipitated by the immune system, in some regards, it doesn't matter how well you go to attack the virus. If you don't take that other stuff into account, you're going to have a bad outcome. Hydroxychloroquine actually has as one of its treatment side effects a reduction of the inflammation.
Mm.
That may be it's most important, that and the fact that it gets the zinc inside for the zinc to work.
Right.
Okay.
Right. Yeah. Fascinating. Fascinating stuff. Let's spend a few minutes. I really want to be able to let my listeners understand this FMTVDM testing protocol that
Right.
you've got. So let's get as deep into it as we need to
Okay.
before we finish up here. So you've discovered then that inflammation is basically the root cause of so many of these issues: cancers, COVID-19, and infections, bacterial, viral infections, as well as heart disease. And you're thinking, how can we figure out what works to treat this stuff?
Right. Right. So first, let me give you the full name, and then you'll
Mhm.
appreciate FMTVDM.
Yeah.
It's actually called the Fleming method for tissue and vascular differentiation and metabolism using same-state single or sequential quantification comparisons.
Nice.
Mouthful.
Yeah.
FMTVDM. Okay?
Okay.
All right. Basically, what I'm doing is after the camera is calibrated, and there's more than one way to do this. There's not a single way to do it. It's all covered under the patent. There's not a single isotope that can be used or a single camera. This is applicable with all of these things.
And so you're still using the same. It's based on the I don't know what the test that you were doing for heart disease with the radioactive material.
Yes, yes.
And
What
but you've refined the technique and expanded it.
Right. So what I do is once the camera is calibrated, I give a drug
Hmm.
to shift blood flow to where there's more blood flow. It enhances blood flow and enhances the differences in blood flow from area to area. And then I give an isotope that follows that increased blood flow and is taken up by cells of the body. And the more metabolically active they are, the more they'll take up.
Right.
So it's that simple. It is looking at the differences in regional blood flow and metabolism. Good hearts have better blood flow and better metabolism than bad hearts. Cancer has more blood flow and more metabolism than precancers, than infections, than inflammation, than normal, than dead.
Hmm. Hmm.
So it turns out that thank you for the cancer work that we did. We had already worked out in more than 1,000 women the differences in infection and inflammatory changes going on and the subtle differences in blood flow and metabolism that shows up as a result of that. I mean, who knew? The test looks for differences in regional blood flow and metabolism, which allows it to look for every one of these things, including including COVID-19. So
Right.
when COVID-19 comes into an area, and it increases the blood flow and it's increasing the metabolism because the virus is activating the cells to be more metabolically active. The white blood cells, your immune system to respond to it, are more metabolically active than what's normally there, and they're being drawn by more blood flow. An area that has an active infection and inflammation with COVID will have more blood flow and more metabolism. If there's a blood clot there, guess what happens to the blood flow?
Right.
Gone.
Yeah.
Are you going to see any of the isotopes show up there or be able to be measured there? No, it's a blood clot. Nothing's getting there.
Hmm.
So you'll be able to see blocked zones. You're able to see just how active the infection is, because the more the reaction is going on, the more metabolically active it will be, the more blood flow there will be. So
Hmm.
you do this up front, you start a treatment. If the treatment is treating the virus and calming the inflammation, what you will see is that the FMTVDM numbers will drop. They will show less blood flow and less metabolic activity, and they will go towards normal.
Right.
If the treatment didn't work, the infection isn't going to be bothered, the immune response is going to be the same, and the next time we repeat the study in 3 days, those numbers are going to go up. Oops, treatment failure.
Yeah.
If they stayed the same, then you have to say, well, wait a minute, either it had no effect or it prevented it from getting worse. And that's where I say, add treatment, don't subtract from something that may already be working. You will soon find out in another 3 days what's working.
Hmm.
And so this way you can track what each treatment is doing by looking to see how the treatment affects the virus and the immune response to the area. Did that do it for you?
Yeah, I mean,
Okay.
it sounds incredible. Like again, why are they focused on the testing and not focused on the treatment right now
Right.
for COVID-19? It's just
Right.
almost mind-boggling.
And or testing that actually shows you whether the treatment works. I mean,
Yeah, right.
you hear this all the time. When are we going to have a treatment or a vaccine? We'd better have a treatment a long time before we have a vaccine. In fact, maybe
Yeah.
that's the problem, right? Because once you have a treatment, do you need a vaccine?
Yeah.
Right? Because let's be honest, if the numbers are right, if 98 to 99% of the people are going to respond to this like they do other viruses and go, okay, not the greatest feeling in the world, I'm better, Okay? And I don't have to go into the hospital. Don't need
Yeah.
anything else. Well, you don't need a vaccine for that. That's your immune system, and that's what's supposed to happen in a human body.
Right.
If, however, something worse is going on, that vaccine didn't do anything for you anyway. What you want, and I've said this before, I don't think anybody's afraid of catching COVID. They're afraid of dying from
Yeah.
COVID or with COVID, to be more accurate. Okay? So the treatment here focus should be, let's keep the people that have the infection from dying with COVID. Because let's get real frank about this. Everybody out there treating patients has a family member or a friend who could get infected. If that doesn't bring it home for you, I don't know what will. When
Yeah.
I was a senior medical student and I was an honor student, my sister was in a motorcycle accident. She flew over the motorcycle. She had a midbrain bleed. She should have died. 99% of them die immediately. The numbers aren't good after that. I got her back after several days. Went
Hmm.
and got her from another state where they were killing her. Brought her back. Okay. When my classmates found out about that, they were shocked. They said, we heard about your sister, and we're so sorry. I mean, people who hadn't talked to me for a couple of years, because they were on other rotations, found me in the mailroom and said, we knew we'd all get into this place where it would affect us personally. We just didn't realize it would affect any of us this soon. And the way that the word got out was because of the brain bleed. She was put onto a neurology rotation, and she had been married, so her last name was different than mine.
Hmm.
All the chart said was that her brother, who was a medical student at the university, along with a flight nurse, who were both credentialed to do air transport, had gone to pick her up and brought her back. So they were sticking things under her toenails in her foot that she couldn't move to try to say, can't you move? And I came in the room and I saw that and I said, "What are you doing?"
Yeah.
And the neurology resident said, "What are you doing here, Fleming?" And I said, "What are you doing?" She said, "Well, what's it to you?" And I said, "What are you doing?" And by that time, the attending was staring at me. She says, "I'm checking for reflex." And I said, "That patient has had a midbrain thalamic bleed and cannot move the right side of their body, which is documented in the patient's chart." And she stepped back, and even the attending stepped back. And it's like, and the reason why I know that is because that's my sister.
Mm.
You don't need to do that anymore. Sorry. I mean, that was my sister. And I realized that got
Yeah.
intense because I could feel it's like, you don't do that to human beings.
Sure.
This is not a game. This is not a joke. These people are dying. These people are scared. They're being made more scared by the information being fed to them to go hide in your homes, go put a mask on, believe that everybody has an infection. They're going to kill you, or you're going to kill everybody else, and just wait for us to come up with a vaccine that's going to cost $3,000 or whatever we want to charge for it,
Right.
or charge you remdesivir. But for the love of God, don't take hydroxychloroquine, or don't listen to your doctor, because your doctor might be right, and that's just going to take away from it, and that'll take away from the fear. You know what? Quit causing panic. Start pretending like you really care about the patients. Conduct studies that actually measure what's happening in the tissue. This is long past due. There's no excuse for it. We've got the best universities, the best hospitals, some of the best doctors, some of the crummiest doctors, some of the crummiest hospitals, some of the
Right.
crummiest universities. Okay. But we've got some of the greatest. And we have people that day in and day out, I hear from them the compassion and the concern for taking care of these patients, and they want to be allowed to do their job. And instead of handcuffing them or pulling the wool over their eyes or telling them they can't do something or threatening to put them in jail or threatening to take them to court because they're trying to do the best thing for the patient, when you have no better answers, you really should stop it. You should really start thinking about the patient and the people that are scared, because there's nowhere that I go that the people aren't panicked.
Yeah.
And why?
I've been upset with the corporate media again for that very same reason. Like, as soon as something like this happens, you really have to make a choice. Like, you either need to help calm people down, which seems to me, the logical thing to do, because living in a state of panic is not, conducive to coming up with the best solutions.
No.
And it just seems like they've been amping and amping up the fear, and I don't know what to do. I mean, that's why I have conversations with people like you to try to take a step back. Look, there's solutions, there's ways to approach this that make a lot more sense, and hope that people can get a little bit of distance from what they're getting inundated from the corporate media every day. That's trying to keep them on edge and trying to keep them thinking that this invisible virus is lurking around every corner. So
It's a virus. It's going to infect people. It's not going to stop infecting people. There's
right.
going to be another one after it. This is really, in some ways, I've considered this. It's really kind of verification of the inflammation theory, for lack of a better way to look at it. And it's really kind of our event horizon as a species, I think.
Hmm.
This is where we make a decision about how much we want to intelligently think about things, or how much we want to behave like primates and scared chimpanzees, because we hear a sound in the bush. We can either
Right.
approach this intelligently and calmly and rationally and do the work that needs to be done to investigate the drugs and the treatment responses, or we can continue to scare people and manipulate people, which I suppose is great. If you have a power thing and you want to do that, I think you are probably being fed better than you should be. But you are scaring the blazes out of so many people that are expecting, that are asking for help, and they will surrender to you whatever you want for the promise of safety.
Hmm.
The problem is the promise of safety that's being held out is a carrot on a stick, and it's not a promise of safety. And it's not even coming with the compassion of really caring. Yeah, I'm unconvinced of those who stand up and go, "We really care. We stay 6 feet apart, wear a mask, don't spread it to other people." Okay, this is July 2020. We've had more than enough time to approach this intelligently. The people that are approaching it, the failure or the lack of people to want to share real data, real information, and to attack people that are not standing up and spouting the status quo is a marker that there is a major problem. And it's not the absence of the ability to solve this problem, it's the desire to promote fear and anxiety and use this to manipulate for whatever purpose they can.
Yeah. Yep. I think unfortunately that's true. And I am starting to agree with you. I think this is a kind of an event horizon. It's like either we're going to keep going down this path and keep just following uh, whatever these people, these power hungry people who seem to have some kind of a larger agenda going on, or the species is just going to, we as individuals really have to each make the choice to say, no, I don't need to follow that path. I can make choices for myself, and I have the ability to step back and not be manipulated and not be controlled by fear mongering. Yeah.
You can change my point of view on anything that you present a logical, intelligent, rational, scientific argument for, but you will never browbeat me or get me afraid of you or use fear or manipulation to get me to change my opinion.
Yeah. Yeah.
Be real or be fake. I hate to use that term these days, but you have a choice. You have a decision to make. Everybody has a decision to make. Um, Even when they try not to make a decision, they are making a decision.
Well, I hear you. It looks like we've been talking for about 2 hours, so probably time to wrap it up. I think I could
I
talk
agree.
for forever if we really wanted to get into it, because there's so much. But we've covered this quite well. We've hit a lot of points today, and I think we're able to to get some of these ideas across. I think especially the importance of the inflammatory response and the ability of your testing methodology to be able to really catch some of these treatment protocols earlier on than they've managed to do it so far with COVID-19.
Yeah.
That's for sure. So if there's anything else you want to touch upon, or if you just want to let people know maybe where they could find out more or find out how to learn more about the FMTVDM.
Well, first, let me say thank you for inviting me on. And I'm hoping that the information that I shared is helpful for people, not only to allow them to see kind of really what's going on, but that there are answers. There may be some barricades, but this is an opportunity for people to take advantage and try and do something. As far as FMTVDM, I think if they go to FMTVDM and Wix, WAX, I think that's the link to the website that allows you to look at not only the inflammation theory, but the heart test and the breast cancer and the cancer test and COVID-19, which, has other information in it. We will, as I said, there is a book. It's simply titled COVID that I'm not sure how long it would take to get out. It's gone to a couple of different publishers for them to look at. My hope is sooner than later, so that it answers questions. It answers basically how viruses do get into your body, how they use your body, a lot of terms that people aren't going to be familiar with. But at least you know that it's not magic, it's science, and it's not something that we're clueless about. Lots of information about what does work to reduce the spread of this virus or any virus. The history of infections, including the history of this virus, and how many it can be traced back now a couple of decades, even though it may have only appeared in the world stage that we know about last year. There's data to show that it existed beforehand. Data to talk about testing, what the different tests do, when they're valuable, when they're not, the different drugs, treatments that are available in ways that you didn't realize that these drugs worked, including some of the antibiotics that supposedly can't work for viruses and how they do work for viruses, including viruses like the Zika virus. And yet the WHO continues to tell the world that there is no treatment for Zika virus. There is. And then just a little bit on where we're going. And there's a lot of information there, but I think the importance is to have something that you can look at and go, okay, this is not something that is from out of this world. This is something that follows science. This is something that they have data on to address. This can be addressed treatment-wise. This can be tested, but not by the tests that they're espousing. And we don't have to run around and be afraid anymore. We literally, as a society, I don't think we can tolerate much more of this. I think we've demonstrated just exactly where the limits for the survivability of human society is. We've done a good job of just pushing it right to
Right.
the event horizon. And if it, the reality is, once it gets pushed back, that the event horizon is not giving. Once you pass it, that's it.
Sure.
And
Yep.
that's not meant to sound to make fear. That is meant to say, why don't we pretend that we're actually rational beings again and behave like it?
Yeah, I hear you. Time to do a little revisitation to our cultural principles here.
I think so.
All
Yes.
right. Well, really appreciate you coming on the show. I'm just going to take a minute to let everybody know that you've been listening to The Shift. I am your host. My name is Doug McKenty. You can find me at The Shift with Doug McKenty on YouTube and on Facebook. I am at D McKenty on Twitter, and my website is www.theshiftnow.com. You can go on, check out all my past episodes and at least the first hour, and then think about becoming a subscriber. You can go onto my website for $6 a month, and you can see the full second hour of all the interviews that I do. So think about that. And I really appreciate Dr. Richard Fleming for coming on the show.
My
It turned
pleasure.
out to be a great conversation. So yeah, definitely. And think about shooting me an email when the book comes out. Maybe we could do it again.
Perfect. I'll do that. Thank you so much to you and your listeners.
All right. You
Thank you.
bet, Dr. Fleming. Take care.
Bye-bye.
Bye. Well, all right, ladies and gentlemen. I hope you really enjoyed that conversation as much as I did. I have to say, I had my doubts at first, thinking, my God, I'm having a conversation, doing an interview with this nuclear cardiologist. How exciting can it be? But as we got into it, I could really see that Dr. Fleming was passionate about what he's got going on. This FMTV DM technology that he's developed really can, I think, save lives during this time of the COVID-19 pandemic when people are really trying to find treatment protocols that work. I've noticed in the news over the last couple of days, a few people are coming out with protocols. I think Dr. Fleming is coming out with one himself here shortly. So a lot of opportunities out there to really, hopefully put this disease behind us with treatments that actually can work. So, I think the way things have been going, anything to keep people off the ventilators. We've been seeing so many people getting on the ventilators and then not making it off. It's been a real tragic situation, as you all know. And I am hoping, as our conversation really elucidated, that the medical community can really start to wake up to some of these alternative treatment protocols that are out there that have been proven to work. I really was happy that I was able to ask him that question about other countries that are using this hydroxychloroquine zinc, maybe the steroid and the antibiotic regimen, and some combination thereof, where they're really having success. And some of these places are even using his inflammation measurement protocols to be able to determine exactly how well the treatments are working and how quickly patients are turning around depending on what medication they're given. So that was great to see some light at the end of the tunnel. We'll just pray that the pharmaceutical establishment will actually start to pay attention. Unfortunately, I think, as I mentioned in the interview, there was a clinic in Michigan that was using a hydroxychloroquine protocol that actually got raided and shut down by the FBI. So it seems like those forces that are pushing the antivirals like remdesivir and then throwing people straight on the ventilators are really, I don't know, I can't imagine exactly why they're clinging to these attempts at treatments that are not working and then not paying attention to other treatments that are. Um, but the level of corruption, as Dr. Fleming and I discussed, is starting to become tantamount to murder, it seems, in my book. The peer-reviewed literature that's out there about the fact that it's not a typical pneumonia, that it does cause this kind of inflammation that Dr. Fleming is expert at diagnosing and treating, almost more similar to heart disease, where the inflammation gets so bad that you start to see more and more blood clotting as the arteries break down, and then people can't breathe, and being on a ventilator is not going to help them. So the treatment protocols that are being used in the United States and some other countries really not working, whereas alternative treatments that could be tested in real time with Dr. Fleming's methodology do seem to be having a positive effect. So I hope that somehow the world can transition to looking at some of these treatments with a different eye, because I personally believe, and not being an expert, I don't know, although very, very nice to be able to talk with somebody who is an expert like Dr. Fleming to reinforce that these treatment protocols do have a lot of promise, and there are testing methodologies out there that can really turn things around quickly if we can get the establishment to start paying attention. So I want to thank Dr. Fleming for coming on the show. It really meant a lot. Turned out to be a really interesting conversation. And if you're out there and you're in the medical field and you're interested, definitely look into this FMTVDM. Dr. Fleming is basically giving it out for free right now to get, to try to turn things around with what's going on with the COVID-19 pandemic. So get in touch with him. You can get in touch with him on his website, www.fmtvdm.wixsite.com. He's given the licenses out right now, so get in touch with him, get it out in the field, and start saving lives, because, we got to start turning this around, and we got to start having some positive feelings that it can be turned around. Just watching the case numbers climb, Thankfully, the death numbers haven't been following so far here in the United States, but until they start taking some of these other treatments, you know, understanding their real potential to help treat this disease when people do get sick, I'm afraid that we're just going to see this go on for a long time. And unfortunately, the establishment seems to be happy enough to just wait for a vaccine or push these antivirals that haven't been working so far. So I don't know what we can do as a people to try to change that. I think if I got sick, I'd be calling Dr. Fleming. So, if it's a personal choice, I'm staying off the ventilator and I'm thinking about taking some hydroxychloroquine, some zinc, and some of these antibiotics, or looking into some of these steroid protocols that seem to be really helping. So, very happy to have been able to have that conversation with him. Guys like Dr. Fleming really show us that there is light at the end of the tunnel. So much bad news over and over again, constantly being hammered, when I think there's good news. There's good news out there. And if the corporate media doesn't want to tell it to us, then we'll leave it up to shows like this one and the independent media to let everybody know that there are alternatives. And it doesn't have to be as scary and as frightening and as we're led to believe by the corporate media. So again, thanks to Dr. Richard Fleming for coming on. If you want to find out more about his work, that's www.fmtvdm.wixsite.com. And you can catch The Shift with Doug McKenty on YouTube or Facebook. I am at DMcKenty on Twitter. And my website is www.theshiftnow.com. Check it out. I've got all of the free episodes up on the blog site. And of course, you could think about subscribing if you haven't already become a member. That membership gets you into the membership forum where we can have some great conversations of our own, and you can help me determine the direction of the show. So, hope to see you there. All right, thanks everybody for checking this one out, and I'll see you on the flip side. Take care.